Before we get started with the last segment, I'd mentioned a little bit over the lunch hour that we are growing and refreshing our quality and quality improvement team at our Pediatric Health Network. And I just wanted to introduce Dr. Claire Bogard and Dr. Ed Fox. Actually, you're going to stand here on the microphone in front of the camera, take your mask off so that people can sort of see you for a second. Take a deep breath. Yeah, exactly.
Thanks for having us, you guys. We joke that it took two of us to replace Ellie Hamburger, so
yes, exactly.
We're very honored.
And Claire and Ed are going to be working with you and your practices around different quality projects and initiatives to improve our care and our outcomes and help our practices thrive. So welcome to your new roles. Thank you. Look forward to getting to know you guys. All right. Moving on to our last clinical section, I'm thrilled to, here we go. Introduce Dr. Anisha Abraham and team. Anisha, I'll have you introduce your team. As we've learned from the pandemic, there's been an explosion of mental health concerns over the last couple of years. And part of that has been a dramatic increase in the number of kids presenting with eating disorders. So, Dr. Abraham, you're up.
Well, thank you, Dr. Weissman, and thank you all of you for being here today. It's wonderful to be back in person in an event. I'm Anisha Abraham, and I'm the medical director of the Delaney Eating Disorder Center. I'm also the acting chief of our Division of Adolescent Medicine at Children's Hospital. And I just want to introduce my team as well. I wanted to introduce Kathy Volgmayr, who is our social worker in our Delaney Eating Disorder Center, and we'll be talking to you about family-based therapy, as well as Emma Gall, who is our nutritionist. And we have no conflicts to disclose. I just wanted to maybe ask by a show of hands, how many of you have worked with a young person that's been struggling with body image or an eating disorder related issue? All right, quite a few of you. So I hope that this session is useful because we're going to be talking about some very practical things. We would like to provide an update on some key screening techniques and thinking about that from a multidisciplinary approach. We'll talk about, again, some management-related issues and, more importantly, also provide some resources and certainly how to get in touch with all of us in terms of those patients that you're seeing in your busy practices. And I'll just start by saying that eating disorders such as anorexia and bulimia and acute food restrictive intake disorders have all tremendously increased over the last few years. And I can say certainly in my time during the pandemic, we've seen actually a doubling in terms of the number of young people that are coming in for these issues. A study by the CDC showed that, again, there's been a doubling of young people that are coming in through our emergency rooms, ages 12 through 16 for eating disorders. I can certainly say from our inpatient service, we've also seen a similar trend. And not only are we seeing patients at much higher volumes, but also coming in with much younger ages with a lot more comorbidities and staying for longer periods of time. So certainly these are huge issues that we're seeing across the spectrum. And I think many of you are also experiencing that in your practices. So what are some of the questions that we're receiving right now? Certainly some of the questions that I think many of you have, which are, how do I medically manage someone like this in my busy practice? I have so much going on. What do I do? Why have these numbers increased? What are some things that we can do to, again, address some of these issues? What is family-based therapy? How do I introduce those concepts to my patients? How do you manage issues like ARFID? What if I can't get my patient into care, or if it's really difficult and I don't have a lot of time? And when does my patient need to be hospitalized? So we're certainly going to address some of these issues. And again, if you have additional concerns, also ways to contact all of us if you, again, have additional concerns or questions. So what are some of the causes for eating related issues? Well, I'll certainly turn it back to all of you as to why some of these things are increasing, but I'll mention that just the advent of Zoom and the pandemic, we're seeing more and more young people that are looking at themselves on screens. And certainly if you think about young people who are also feeling very kind of self-conscious about their identity, looking at themselves over and over can really increase, again, the likelihood of challenges related to their body image and self-esteem. Of course, we've also seen more young people that are feeling stressed or spending more time at home. There's also an increase in food insecurity. And what we do know is that in those families where there's increased food insecurity, we're also seeing that there's an increased likelihood of doing things like restricting their intake and binging, using laxatives and diuretics. So there's actually an association. Of course, we've also seen many more young people coming in for issues related to anxiety and depression. And I know you've had some discussion of that earlier today, but certainly alongside of that, we're of course also seeing young people coming in for eating related issues. There's some thought that eating is one thing that young people can control. And when they've lost control of so many other things that are happening in their lives, that's the one thing that remains. Of course, even just using masks, I've had young people tell me that they're afraid to now eat in public and they don't want to take off their mask. So there's something else to consider. We also know that a lot of our work has been done virtually, not seeing patients in person and knowing what their weights are checking and seeing how they're doing, maybe one piece of that, but it's also been increased wait times to get in for care for mental health, for example. And finally, how many of your patients are on social media and use things like Instagram and TikTok? Well, there's been a very strong association, and I think there's a lot of good things that come out of social media, but there's been also a strong association with those young people that are on things like TikTok and Instagram, an increased risk of binge eating and other eating related issues. So what are the different forms of eating disorders that are out there that you may see? They include things like binge eating, but certainly anorexia, bulimia, and avoidant restrictive food intake. And we do know that there's an association with things like early puberty. For example, when you go into puberty, there's an increase in fat composition, and that for some young girls in particular can be a real trigger for them. We also know that having a family history of having an eating disorder or mood or anxiety certainly puts them at higher risk. Of course, alcohol and substance use, and the peers also have a lot to do with that. So certainly if young people are with other young people that are really focused on their weights and their body image, that can also have an impact. What I think is really disturbing is that 81% of 10-year-old girls right now are concerned about being too fat. And we certainly are seeing not only girls, but also boys that are struggling with these issues. And I will also mention that you're going to be having a talk later about young people when it relates to those that are LGBTQ. And I'll also say that those young people are at higher risk also of some of these issues. But we do know that half of US girls right now say that they're struggling and are doing things that are unhealthy to control their weight, and about 1/3 of boys. And I'll finally just mention that eating disorders is very much an issue that happens during adolescence, but I will also mention that it is one that we need to think about in terms of mortality. And in fact, young women in particular that presents for anorexia is 10 times more likely to die than her another peer that wasn't struggling with these issues. So these, again, are really important things for us to be aware of. So what are some of the things that all of you need to think about in your busy practices to be able to determine if someone's at risk, and certainly if they need further evaluation or care? Well, I will just remind you of what we call the psychosocial interview. We call it the heads or shades interview in our adolescent clinic, but thinking about what those strengths are, who they live with, what's happening in their school, and certainly what their dreams are for the future, what they're doing for fun. Of course, asking more about a detailed dietary intake, certainly asking also about sexuality and safety, or other pieces, and suicidality or other parts of that shades interview. The other specific tips that I'd like to give all of you as you're thinking about this, you have a young person, is asking about body image. And one question that I'd like to ask is, when you look at yourself in the mirror, what do you see? And do you want to change that? And certainly I've had young people that have come in, I really don't think that might be an issue. And then when we get to that particular question, there certainly are some real things that come up in terms of red flags. Other things that I want to encourage you to think about is if there's a significant change in weight. There's a young person that's suddenly become a vegan or a vegetarian. Those can be red flags as well. There's a huge increase in exercise, and we've seen with the pandemic that kids have sometimes become a little bit more overweight or obese and sedentary, and as a result try to compensate with an increase in exercise. I will also mention that we talk about the menstrual cycle as that fourth vital sign, but if a young person comes in and suddenly stopped having their menstrual cycle or is not having their menstrual cycle when they need to, again, talking about these issues are important. Finally, I'll also encourage you to think about things like purging, laxative use, and we've mentioned social media and things like TikTok. Other little tips to be aware of for young people that have a history of ADHD, there's certainly concerns about impulse control. So being aware of that, asking about it, and certainly knowing that that may need to be something that needs to be treated is really important. And the other piece that I really think is very much important for all of you to think about is that 1/3 of young people that are now coming in for an eating disorder probably have some association with being obese or overweight. And we certainly have seen young people come into our practice in our outpatient center, much less inpatient, where a well-meaning provider may have told them they were overweight or obese. And as a result, they started to restrict their intake or take on unhealthy practices to try to change that. So certainly how we present that information is also very important. So what are some of the things that you want to think about when you're seeing a child or adolescent and you're concerned about these issues? Well, I would certainly encourage you to think about getting electrolytes, thinking about also calcium, magnesium, and phosphorus. For those that are coming in that might have a restrictive component or you're concerned again about the malnutrition, thinking about an EKG to look for bradycardia, certainly, of course, looking at their vital signs and also their orthostatic blood pressures. Also adding things like a thyroid function test would be others to consider. And I love that we had a discussion just earlier about bone health and vitamin D, but certainly looking at vitamin D would be another piece of that. And finally, I would just really encourage you to think about the fact that when we are getting weights on our young patients, trying to not make weight the focus. And a lot of what we do in our practice is really take weight out of the equation. And if they are coming back to follow up for issues, a lot of times what we do is to do what's called a blinded weight. The patient turns away and is not facing the scale. And we instruct our nursing staff to really help with that. And of course, having them into a gown can only also make sure they have an accurate weight. So I will just remind you that the management of eating disorders is very much involving a multidisciplinary approach. So certainly you as a medical health provider can do a lot in terms of those initial assessments and asking questions and making sure you understand where they are in this continuum, but also involving, if you can, a mental health provider and a nutritionist can be very important. And we're certainly going to hear more about those elements in a moment. Other tips that I just wanted to impart include thinking about the importance of, again, counseling and nutritional repletion. For those patients that may have anxiety or depression, certainly thinking about adding medication. This is something you can certainly feel comfortable doing in your own practice, and thinking about medications like sertraline or fluoxetine as part of that. For those patients that are having a lot of anxiety before meals, you're trying to encourage them to get regular meals, thinking about additional medications to give either at nighttime or pre-meal can be other things that you can start to do in your practice before you're referring them out, or if you're, again, waiting to get them into the next level of care. And I'll finally just mention for those patients that have restrictive intake related issues, a lot of times the malnutrition causes slowing of metabolism and a slowing of gut motility, and thinking about adding osmotic or bulk forming agents can also be very helpful to those patients. So I will now invite Kathy to speak a little bit more about family-based therapy and some of the things you need to think about when you're approaching your patients.
Hello. I am curious to know how many people have heard of family-based treatment or FBT. You may have, who has heard of the Maudsley approach? Basically, FBT has its origins in Maudsley, and they're pretty much used synonymously these days, even though there's some very subtle differences. But FBT is an evidence-based intensive outpatient treatment where parents are playing the central role of restoring and refeeding their children and restoring their weight and health. As medical providers, when a family comes in, it's really important to remember that parents are not to blame. Often, the parent will come in very upset. What did I do to cause this? What do I do to change it? And it's really important to refocus the attention away from causes, which we really never know for sure, and get the parents refocused on food becoming the medicine to cure their child. Often they'll think, oh, well, first my child has to have a better body image. And that often is not the case, nor will it happen until we get their brain renourished. And so just realizing that the patient's insight and motivation is neither needed or expected when treatment is begun. And in fact, FBT has been proven more effective than other treatment approaches that do prioritize insight or motivation to get better. So there are 3 phases of FBT. The first phase is where the parents are most involved. And this is where we really speak of nutrition and food as medicine. Parents control all nutrition and any other eating disorder behaviors. So they'll be preparing, plating, and supervising their child. They will also be supervising for things like over-exercise, making sure that isn't occurring, and for any other compensatory behaviors such as purging. And Emma might talk a little bit more about that. So again, what are some things as providers that you can do? You really want to be thinking about how to get the patient back on their own unique growth curve. That doesn't mean we want to have an exact target weight. We'd rather emphasize, again, just getting them back on their curve. Often, if a child or parent hear a target weight, they think that's a final weight. And we don't want them fixated on that number because that's a number that will probably change with growth and development. So at appointments, you are wanting to get the patient's weight, height, and their vital signs. Obviously, if they are not medically stable, they will need to be hospitalized. If things are going well and parents, have begun the treatment, and hopefully there will also be a full team in place of a mental health clinician, the primary care provider, nutritionists, and sometimes a psychiatrist as well, and a dietitian. There'll be a full team. And so hopefully there will be communication amongst all the team members. But as soon as you can decrease the frequency of visits, as long as the patient is medically stable, that's great, because there can be a lot of different appointments between the dietitian and the therapist. So really just supporting parents, helping them trust the team, reminding them that, they are in the best position really to treat their child, because nobody loves their child as much as they do. They knew how to feed their child just fine before the eating disorder, and they can do it again now. And just that it's not, a lot of times people see it as a treatment that's less intensive than higher levels of care, which is really not necessarily the case. Doing family-based treatment for the parent is extremely intensive. It's just the parents really playing the role that a doctor or nurse might be playing in the hospital. So I will turn it over to Emma.
So now we'll delve a little bit more into the nutrition basics, but I think it's important to note that there is no consensus in the field of dietetics regarding specific meal pattern or meal plan efficacy. So across the field, you might observe a variety of different approaches to meal planning. The Academy of Nutrition and Dietetics does approve of what we use, which is called the plate approach, which is used by our outpatient clinic and typically always in conjunction with FBT. Plate by plate was actually developed by two eating disorder dietitians. Essentially, we find that the plate by plate method is a better transition to intuitive eating compared to more rigid meal plans that overemphasize numbers and calories and exchanges. So instead, what I will do is I will sit down with the patient and I will give them one of these two meal plans. And you can see below the picture, who might be indicated to use which meal plan. And from there, I will go over each food group, why it's important for their recovery. And I will also prescribe a certain amount of snacks, and snacks are usually comprised of two food groups. So in my mind, I'm keeping track of the calories. I know the energy that the patient is generally getting, but it is not something that I generally talk about with either the patient or the family. But to offer some more concrete guidance, because some parents do want that, I will always give a list of general portion sizes that they can use during meal times to make sure that their child is getting enough to eat. But I always advise that the parents don't measure, especially in front of their kids, because I think that just plays into the rigidity that eating disorders kind of already are rooted in. And like I said, the plate by plate approach is typically used in conjunction with FBT. And I also offer parents the following general advice after our first visit together. Patients should be eating every 3 to 4 hours at this point. And this is to establish normal eating patterns and to regulate hunger cues, which a lot of times have gone away with decreased energy intake. All meals and snacks must be completed or supplemented accordingly. And so my supplement guidelines, so 1 nutritional shake equals half a meal or 1 snack. 2 nutritional shakes would equal a full meal. So many dietitians will practice mindfulness with their general patients. With eating disorder patients, I actually prefer to encourage distractions at meal times, and that's simply just to reduce the anxiety around the food. And that's because our eating disorder patients are already overly mindful about everything that they eat. And so I'll encourage them to play games, read, watch a funny TV show, or just eat with their friends or family. That said, that there should be a time cap on mealtime, so it shouldn't exceed more than 45 minutes to an hour. And this is because any longer than that just prolongs unnecessary anxiety. Of course, small 5 to 10 minute breaks are okay during meal times. And finally, there should be no bathroom use for patients who are suspected of purging within 30 to 45 minutes after meal times. And finally, I wanted to note that with ARFID patients, we go about nutrition a little bit differently. It does adopt a lot of the same principles, but ultimately I'm worried about correcting malnutrition first, and then I will tackle a variety of foods later and maybe expand the horizons of what their diet already consists of. So for specific nutrition needs, I often refer to the Academy of Nutrition and Dietetics Pediatric Nutrition Care Manual. Many of the patients I work with have high energy and protein needs, and this is usually for repletion or weight restoration. And the manual states the following in reference to energy or calorie intake during repletion. We use the RDAs, or recommended dietary allowance, or resting energy expenditure times a 1.5 to 1.8 activity factor, and then we increase as necessary to maintain weight gain. And sometimes it can be up to 3.5 or a 4.5 activity factor in extreme circumstances. And of course, all energy recommendations are pending stable electrolytes. And then for protein, for repletion, I offer 1.5 grams of protein per every kilogram of ideal body weight, not current body weight. And I also try and emphasize high biological value protein sources whenever possible. And then for fat, I think it's just important to note that The patient might need a higher than recommended fat intake simply to achieve caloric goals. And then for fluid, that depends on symptom use. And so the manual states if a patient has been restricting fluids, then we need to set a fluid minimum so that they're not dehydrated. But if patients are water loading, we need to keep it to basic maintenance needs. And then I also thought it would be important to note that some nutrients of concern to look out for in your practice are things like vitamin D, iron. You can look out for calcium as well. And then regarding ideal body weight, I did want to just say that I use a number that puts the patient back on their unique and predetermined growth curve for BMI. And for patients in larger bodies, we sometimes have to just put weight loss on the back burner. And sometimes for patients to heal their mindset and their metabolism, they often have to return to their usual body weight for recovery. And even if that means that it is an overweight or sometimes an obese BMI.
I just wanted to mention that there are a variety of levels of care for our patients that have eating disorder issues. And many of you are going to see patients on an outpatient level, but if you are concerned, they may need a higher level of care or more support than thinking about an intensive outpatient treatment or partial hospitalization, in some ways up to residential or inpatient care. And we can certainly help you with all of those levels of care. Sometimes that's the more complicated thing that you're dealing with is how do I support this family? What do I need to do next? Where can they go? I will again mention that at Children's, we do inpatient therapy. So if a patient truly needs to be admitted, we do medical stabilization. We work on nutritional replenishment. We will sometimes give them an NG tube and certainly a lot of work with a multidisciplinary team. And of course, we will also help with outpatient therapy. You've seen part of our team here, but again, we can help on the outpatient. But as I mentioned, if there's additional levels of care, we're there to also provide some resources. This is our team that does outpatient care. I will just remind you that we have someone available at the hospital 24/7. If you have a question or need some additional information, so you can certainly page the adolescent medicine provider on call if you're worried that someone needs to be admitted. You can also contact our clinic if you have a patient you'd like to refer. We have an email that we check regularly, eatingdisorders@childrensnational.org. And I will also refer you to our website that has a lot of resources for both patients and providers and also in Spanish. If you are concerned about a patient needing to be admitted, I just want to remind you, these are our specific criteria. A heart rate less than 50, there's severe electrolyte disturbances, there's acute refusal. For example, they've gone several days now, they're not eating, or they're eating consistently about less than 500 calories a day. And again, I want you to remember these criteria because you might be worried and you want to think, does this patient need to be admitted? You certainly can, again, feel free to contact us at the hospital, but these are some of the questions we'll be asking you as to whether or not they truly need to come in and be stabilized nutritionally. Again, I will just remind you, this is our inpatient team, and certainly it does take a village, but our team includes, of course, our adolescent medicine providers. We work with psychiatry. Psychiatry is also very much a part of our assessment. Certainly, we also have a nutritionist, social worker, case management, child life, and our dog therapy is a very important and popular part of what we do also for our inpatient care. So I will remind you that these are some of the common questions that, again, many of you have that we certainly tried to address in the short time that we had today. But again, I hope that you will certainly remember that we're seeing more and more, again, in our outpatient practices of young people coming in with these issues. Don't forget to do that heads or shades assessment. Ask about some of these very specific questions. Think about that multidisciplinary approach. We've talked a little bit about family-based therapy, so your patients may be candidates. We've also talked a little bit about that plate-to-plate approach, and those are things you can start to incorporate or thinking about adding additional supplementation. If they're not eating, again, 2 cans of a supplement for a full meal, a half a can for a snack. Do think again about levels of care, and as I mentioned, certainly reach out if you have any questions. These are some additional resources that are available. These are also on our website, and our website, of course, is located here. So I'll end and see if there's any time for questions.
there've been a couple questions, and I think we're going to limit it just to one. And you've shared the resources. It says FBT in its purest form is quite difficult for families to commit to. Do you recommend we modify FBT principles for our parents to utilize in the primary care setting?
Want to address that?
I think that parents actually can be pretty easily empowered that they do know how to feed their children, that it doesn't have to be this exact, cup of this and cup of that, that they, with a little bit of help, that even the FBT therapist or the pediatrician can give them what a plate looks like, and really reminding them that the child should return to eat anything they were eating before the eating disorder. With some, with the scariest things maybe coming later, but really anything should be given to the child, and that they can do that, and that they can provide the compassion and support, and they really are in the best position to help their child recover.
Thank you so much.
Thank you.